Dr. Sherman Silber, and I'm sorry we're late. We were going to be starting at 6:30 Central Standard Time, or Central Daylight Time in St. Louis, and we had technical problems causing the delay. I hope you're still there. I'm Dr. Silber, Infertility Center of St. Louis, and we try to answer questions on Facebook Live on a regular basis to anybody that has any questions regarding reproduction of any sort whatsoever. And then I start out with a little introduction of a few controversial things that I give my view on. The first thing I want to talk about ovarian regeneration. Now, I think most people in the world know I'm probably the authority on ovarian aging, ovarian longevity, with my work on ovary transplants, in vitro maturation, in vitro gametogenesis. And so I know about the whole thing about ovary rejuvenation. What's going on right now is basically fraudulent. It's a hokum thing. It's not scientific. Injecting, platelet-rich plasma into the ovary to try to make it young again. It's just absolute. It's quacky is all it is, and it doesn't do anything. Taking mitochondria and injecting it into the ovary to try to get the older eggs young just doesn't work. And none of this is really based on true science. It's just gimmickry to sound scientific. And so you shouldn't be fooled by that. I mean, we have solutions for older eggs, and we talk about it all the time, and we're doing research on it, and it's a very important subject. But I just wanted to tell you, it's going around everywhere. People are always asking about ovary rejuvenation. Now, on the good side, I want to tell you that we've just really made a tremendous breakthrough for what we call Turner syndrome, which could be true of any young woman who has no eggs. And it's not just a matter of egg donation, but if you want to get pregnant naturally without having to, say, resort to donor eggs and IVF, we can now do a transplantation of ovary tissue from a sister or a relative with immunosuppression that is really safe. It's no longer a scary thing. You can do immunosuppression for non-life-threatening diseases, and it's completely safe. And it's transformative because you'll be able to get pregnant on your own. Even though you may not have any eggs now, you'll have a functioning ovary, and the immunosuppression is very easy now. So I just didn't want to miss any other points, but when we get the ovary out, we can find immature eggs, 50 to 100 of them, and we can mature them because we're using the principles of in vitro production of sperm and eggs, which we are researching constantly with Dr. Hayashi from Japan. And using those principles, we can get those eggs now and mature them without any need for ovarian stimulation. So that's really quite a breakthrough, and we're really excited about it. And I can answer all kinds of questions about it. Finally, I make the point that everybody is going for pre-implantation genetic screening or pre-implantation genetic aneuploidy testing, but it's not really a good idea. When we do pre-implantation genetic screening, we're doing it for specific genetic diseases that the husband or wife might have mutations for, might be carriers of. And that's extremely accurate. And we started that ourselves back in 1994. I wrote the first paper in the United States about it, actually. And but if you're just trying to do routine screening in general, that's not to really see if it's a normal baby, because there's 23,000 genes. And those 23,000 genes represent only 2% of the genome. And the rest of the genome is DNA that we haven't figured out well, and it's a regulating process. You can't find that you can't really do that right now. You can't do that kind of screening. You're just checking for numbers of chromosomes, really gross errors. And there are cells in the early embryo that have gross errors and cells that don't, even though it becomes a normal embryo, because the cells with gross errors just die out. And so the error rate is about 40%. Now, it's alleged that the error rate is only 4%, but It's really, really much higher than that in randomized controlled trials, and trials where you compare women that had the diagnosis with biopsy of the embryo of a so-called euploid embryo versus women that just had the embryo transfer without any diagnosis. And the, the pregnancy rate, the baby rate were no different, really. Uh, the only difference is that the ones who had the PGS are worse off because embryos misdiagnosed as abnormal were thrown away. So they actually have a lower success rate. So those are controversial issues I thought I'd start out with. And now maybe let's just go to any questions you have at all about infertility. Just come up with any questions whatsoever.
Yes, Dr. Silber, your first question is from Catherine, and she says she has a question about Malaria Genesis.
So, so everybody will know what a Malaria Genesis means. There are two tubes in the early embryo early in fetal life, really actually as early as 3 weeks of fetal life. There's the Malarian duct and the Wolffian duct. So the Wolffian duct in the female just degenerates and becomes what we call the round ligament. The Wolffian duct in the male actually develops and becomes the epididymis and the vas deferens and even the prostate gland and the seminal vesicles. Now, in the female, the Malarian duct, however, develops into the uterus and the upper vagina and the fallopian tubes. So, Malaria Genesis is a problem that you can't carry the baby, of course, but you will have normal ovaries. So, the proper treatment for that is you have to do IVF and put those embryos into a gestational surrogate who can carry the baby for you. We've done many, many cases of those. It's also called Rokitansky syndrome. Now, I see another question. Can you help?
She added to her question where she says, "Can you help women that have no menses secondary to small uterus?"
Well, I'm not sure if she says Malaria Genesis. It may not be such a small uterus. It may just be no uterus or just a uterine remnant. If it's Rokitansky syndrome, all we have is 2/3 of a vagina. They're missing the upper vagina and the cervix and the uterus and the fallopian tubes. And that's more likely what she's talking about. So, of course, the answer to that is really clear cut. We can get the eggs from the ovaries. The ovaries should be normal, fertilize them with husband sperm, and then we would freeze those embryos until they find someone who's willing to carry the baby. It could be a relative or a friend, or we can find one from an agency, a surrogate, if they don't have one of their own, and transfer those embryos into the surrogate uterus. And we've done many cases like that, and with really happy patients.
Okay, Dr. Silber, your next question is from our last broadcast, and it is, am I guaranteed twins if I transfer 2 embryos?
No, you're not guaranteed twins. You see, if you transfer just one embryo, if it's a day 3 embryo, it's about a 40% pregnancy rate. And if we transfer 2 day 3 embryos, it's 65 to 70% pregnancy rate. And if we transfer, say, 2 blastocysts, it's about an 85% success rate. And but it's not 100%, obviously. And so the chances of twins are pretty high. They can be as high as 30% or 40%. And most centers are really against this because if you look at literature, it looks like there's a higher risk of complications like premature labor and low birth weight infants that would arise from twins as opposed to singleton. But actually, we haven't had problems with our twins. It may just be that really good obstetric care and good prenatal care in a private system rather than just perhaps in an indigent system where most of the papers came from seems to solve those problems. And so we really don't have problems if you have twins. We're okay with that. There's a benefit to twins that nobody talks about, but it's clear cut. And there's no greater gift you can give to any little kid than having a twin sibling. because there's no closer relationship that ever exists between any two people, even husband and wife, no closer relationship than between twins. And so that's a very special benefit to being a twin. But certainly we would never guarantee twins. I mean, we just put in two embryos if the patient likes, because we don't have a problem with twins. And it'll save them a lot of money also, because it's half as many transfers to get the same result. But no guarantee of twins. It's just a possibility.
So, Dr. Silber, Catherine says that she says, "Thank you. I'll be consulting with you and for the previous question." And then your next question is from Dawn, and she says, "Can a 46-year-old use her own eggs for IVF?"
Well, yes, a 46-year-old can use her own eggs, but the success rate is very low, even with mini IVF, which is remarkably good at getting the best quality eggs. And we like to use particularly for older eggs, older women. But when you get up to 46, then it's really getting pretty low. It's if we were to get as many as 6 embryos over the course of 1 or 2 or 3 cycles, it would still only be about for a 46-year-old 5 to 10% chance of success. So, but we do it. It's a tangible result. We have occasional successful pregnancies even with 47-year-old eggs, but we don't have any successes with over 47 years old. Doesn't mean it couldn't happen. We're willing to try it. We're willing to try it up to 50 or 52 years of age, as long as you understand the chances are remote with that such an old age.
Okay, Dr. Silber, your next question from Jimena. She says, "Can you transfer 1 3-day embryo and 1 5-day blastocyst at the same time?"
Well, there's 2 ways of doing that if that comes up. One way is to thaw the day 3 embryo and then culture it to day 5. And if it goes to blastocyst, then you can transfer both of them together. You can't transfer the day 3 and the day 5 together because they'd be out of sync. On the other hand, quite frankly, you could take the day 3 embryo and put it in on the 4th day of progesterone, which is day 3, and then 2 days later, you can put in the day 5 embryo. I don't think there's a big problem as long as we're doing it properly with ultrasound and it's a delicate transfer. I think we could, those are 2 possible ways to do it.
Okay, Dr. Silber, from Kate, she asks, "How many eggs should a 37-year-old freeze for 1 possible baby?"
Well, okay, so the data originally came out a big series from Spain, which were the first people to study this issue. And if the patient was 35 or less, you'd have about a 94% chance of at least 1 baby if you had 30 eggs. But when you get up to 37, we don't have clear data on that, but we would have to extrapolate and imagine that to have that same success rate with 37-year-old eggs as opposed to 35 or younger would probably mean 40 eggs. That is not that you could have several babies from that. That's the percent chance of about 94% of having at least 1 baby. And you might have 2 or 3, but the chance of having at least 1 baby would require, if you're 37, I think more than 30 eggs, closer to 40 eggs. And if we don't know what your ovarian reserve is, if we do minimal stimulation, we'll get the same amount of eggs we've discovered. It's just that they'll be better quality with a much higher baby rate per egg. So it could be better than those figures. It might mean that for 37, we'd only need half as many because we get better quality eggs with minimal stimulation. So we could go for anywhere from 20 to 40 eggs, and then I think you'd feel pretty secure.
Okay, Dr. Silva, the next one from Benny Ann. "I have to do IVF because of my endometriosis and my tubes are blocked. Is it necessary to remove my tubes before doing IVF?"
No, I think you've been given the wrong information in a sense. With blocked tubes, if they're near the ovary side, then they're filled up with fluid. And of course, you can't have an embryo transfer then, because the fluid going back into the uterus will prevent implantation of the embryo. So you don't want to have a fresh transfer. Furthermore, you don't want to take the tubes out before you get all the eggs, because sometimes removing the tube, especially in a case of adhesions, can result in damage to the ovary. So I think the important thing is get the eggs first, fertilize them with husband sperm, freeze the embryos, get enough embryos frozen and stored up, maybe even 2 or 3 cycles, just so you're really certain you've got what you need, and then remove the tubes. But you shouldn't remove the tubes first or delay getting the eggs, because your eggs are just getting older, and the younger the eggs, the better they are.
Okay, Dr. Silber, we have one here from, let's see, from Tasha, and she says, how long do you wait after a laparoscopic procedure to transfer an embryo?
Well, by the laparoscopic procedure, I presume you mean that the fallopian tubes were removed, maybe because of hydrosalpinx and blockage. If that's I'll answer every option. If that's the case, I think you can have your embryo I think I would personally wait 3 months until you know there's no more toxic effect of the drip of accumulated fluid in the fallopian tube down into the uterus. Just make sure all that is over with and gone. Furthermore, before doing the embryo transfer, I would do an endometrial biopsy, which we sometimes call a scratch, to make sure that you don't have endometritis and need antibiotics before the transfer. Because the embryos are precious, and you just want to make sure that you have maximum receptivity that the tubes could prevent. Now, I see another question. What's the difference between laparoscopic and hysteroscopy? Hysteroscopically, you're just looking into the uterus, and if there's a polyp, you certainly do it hysteroscopically right through the uterus, no surgical incision, nothing like that. And then you just remove the polyp. If you have a fibroid that is actually inside the uterine lining, well, then you would shave it off, and it might take several sessions of hysteroscopy to do that, but you avoid an open operation. It's better. But now, other surgery, laparoscopy, means you're going through the belly button, so to speak, and you're going into the abdomen, and you're operating from above. And so typically the tubes are removed laparoscopically, but a polyp is removed hysteroscopically. So hysteroscopy is a piece of cake. Laparoscopy is more invasive. Now, if it's really truly a fibroid uterus that requires, that really requires a surgery through the abdomen, the FDA doesn't recommend laparoscopy or robotics, nor do I, though people do it. I think you can do a much cleaner job with those fibroids with a mini laparotomy. I could explain the technical details why, but I think it's just much safer than removing and shredding up fibroids through the laparoscope. And when they do that, even the best laparoscopic surgeons miss fibroids. Whereas if we do it with a mini laparotomy, we're not going to miss the fibroids. So that's a long answer to the difference between laparoscopy and hysteroscopy.
Okay, Dr. Silber, this is another response from Kate, where she had asked about the freezing eggs for a 37-year-old, and this she mentions here that she's questioning about the man's age.
You don't have to worry about the age of the man. I mean, it's unfortunate for women, but and it's very, very beautiful the way God made this. It's with women, they only have so many eggs when they're born. They don't make any new eggs. And so the eggs get older, and so they get less fertile. Whereas men have spermatogenic stem cells that are making sperm all the time. So men keep on making sperm. They can be 110 years old and they're still making sperm. Not quite as good, maybe 80% of what they made when they were younger, but men just keep making sperm because of the stem cells. Now, why would such a disadvantage be created on one sex and not the other by the Almighty or by evolution, either way? Well, you see, when you have that frequent mitosis, there is a greater risk of mutation. Most mutations don't mean anything, and occasional mutations are detrimental, but mutations are the way that we develop as humans. we constantly are elevating from caveman to Cro-Magnon man and Peking man and the early hominids to what we are now, Homo sapiens. That wouldn't happen without the mutations that occur with spermatogenesis in the testes. But to stabilize the species, what we need are ovaries, eggs that aren't always dividing, that are the same eggs that you had when you were born, and they're not really dividing. So they do get older and less fertile, but it stabilizes the species. So you have this constant balance between the male and the female. The female stabilizing the species, and the male allowing for, over the course of millions of years, evolutionary advance. So the answer is, I think it's fascinating scientifically, but the answer for you practically is don't worry about the age of your partner's sperm.
Okay, Dr. Silber, your next question from Erin, and she asks, how does PESA and/or TESA work with IVF?
Well, the reason for PESA or TESA is if you have no sperm in the ejaculate. PESA just means percutaneous epidermal sperm aspiration. I really think that's a terrible procedure because you're blindly sticking a needle into the epididymis. And frankly, with obstruction, most of the sperm in the epididymis will not be good, even with ICSI or IVF, and you'll get terrible results. People report much worse results with retrieved sperm because most urologists will just stick a needle in called PESA, and you don't get good sperm. What you have to do under local anesthesia, so it's not a big deal and it doesn't really hurt much, is you make a microsurgical incision under a microscope and you look directly at those epidermal tubules and you get the tubules usually closer to the testicle that are making the most fertile sperm. And so microsurgical sperm aspiration, which is MESA, is about 10,000 times preferable to PESA. Now, TESA is only necessary really for non-obstructive azoospermia, where you're really making no sperm, you think, but you're, in truth, if we go into the testicle microsurgically, not the epididymis, there's 60% of the time we find a tiny amount of sperm. So what we thought was a man making no sperm is 60% of these men are making sperm in tiny amounts, too small to spill over into the ejaculate. And so we think they're making no sperm, but we're wrong 60% of the time. They are making sperm, but it's the most tiny amounts. And those tiny amounts are quite adequate for ICSI, injecting the sperm directly into the egg. And I must say, we were the ones that first invented this in 1986 and then added ICSI to it in 1993, working in Belgium. And so we have a vast experience with it. A lot of the doctors playing with this really don't know what they're doing. They're not really scientific about it. So PESA seems easy. You just stick a needle in, you get sperm, but that's not the way you get the best quality sperm. And you certainly won't get very good sperm with non-obstructive azoospermia using PESA. But TESA, I don't believe, should be a crude procedure. It should be done with a microscope. So that's my answer.
Okay, Dr. Silber, your next question is from Haley, and she asks, I have my FET next Tuesday and planning on transferring 2 to 5 blasts. My other blasts are day 6. Are day 5 blasts better than day 6 blasts?
Well, that's a fascinating question. We used to think that day 5 blasts are better than day 6 blasts. But actually, a randomized controlled trial, which is most people don't do, done by Dr. Bruce Shapiro, from when he got his PhD, actually, University of Amsterdam, proved beyond a doubt that the only problem with day 6 embryos is that if you do a fresh transfer, they're out of sync with the endometrial lining. And so if you freeze them, and we do all frozen transfers now, all frozen. If you freeze the day 6 embryo and transfer it as though it were day 5 embryo later on in a cycle in which you know that the progesterone has been given so that it's perfectly in sync with what would have been a day 5 embryo, then it's just as good as a day 5. So the only problem with day 6 embryos is with a fresh transfer, they're out of sync with the stage of the endometrial lining. That is never a problem with us because we feel that frozen transfers, if you know how to do your vitrification and freeze the embryos properly, so you don't hurt those embryos, frozen transfers are always going to be preferable because you'll know that the uterine lining is in sync with the stage of the embryo.
Okay, Dr. Silber, we have another question here from Jimena had made a comment earlier, and she asks also, are the chances better with embryos or blastocysts?
Well, let me explain that. On 14,000 cycles that we looked at, with day 3 embryos, there was a statistically significant, not huge, but a statistically significant higher baby rate with day 3 than with blastocysts. On the other hand, the baby rate per transfer of the embryo is higher with blastocysts. So what that means is that day 3 embryos sometimes don't go to blastocysts in the incubator, but that would have gone to blastocysts in vivo in your uterus. So day 3 embryos seem to be better overall per cycle, but blastocysts are better per transfer.
Okay, Dr. Silber, your next comment is from Islam, and he asks, I am so happy I'm listening to you now. I love this specialty so much. I will specialize it in one day. And then he also says that he's from Sudan.
Islam, it's great. It's great to hear from you, and I know how important it is, and well, with everybody in the world, really. Be fruitful and multiply is the first commandment in the Bible, and also the Quran emphasizes the importance of having children. And so I'm really happy to hear you say that. It must be that you're either pre-med or medical student, and anytime you want to visit us, we'll be glad to show you what we do. I welcome you very much. I've actually been in virtually every country in the Middle East and operating or lecturing, except for Sudan and Libya. But I have patients from every country, including those countries, and I always find it just heartwarming to be there. So thank you. If I can help you anyway, let me know.
And then you have a comment from Pamela. She says, I love you, Dr. Silber. You are the best doctor ever.
Oh, Pamela. Oh, that really makes me feel good. That's people ask me why I don't retire. Well, I figure as long as I still got my marbles and my hands still function well, this is my favorite thing in the world to do. I love to fish, by the way, and I love to ski, and I love to hike in the back country, and I love to play chess, and I love to write. But what I love most is doing exactly what I'm doing, taking care of patients, and comments like that from you. It just, warm me up so much. Thank you so much, Pamela.
Okay, let's see. Here's another question from Jimena, where she asks, are the chances of twins and triplets higher with mini IVF than naturally?
Well, the chances of twins or even triplets purely depends on how many embryos you transfer. So if we do IVF or mini IVF and we transfer one embryo, then your chance of twins, that's a splitting, is maybe as little as 1 in 1,000. If we transfer 2 embryos, if your eggs were young, then you could have as high as a 30% chance of, or 40% chance of twins, depending on the age of the eggs. So you have complete control over that. The chance of twins just naturally is somewhere in the neighborhood of 2 or 3%. And that just is, believe it or not, when you're less fertile and you're older, it's more likely to be twins, because it just means that your FSH was higher and you ovulated 2 eggs instead of 1 egg. So it can happen naturally, but it's not that common. But we can make it very common if you do IVF and you transfer just 2 embryos. We don't want triplets, really. Occasionally, that is a complication of transferring 2 embryos, because one of them might split. And so far, our triplets have been very healthy. We just had a delivery last week of healthy triplets, and we really haven't had that problem with triplets that we fear, but that's only because of magnificent prenatal care, perinatal care, obstetrics, NICUs, that is neonatal ICUs, for the way they take care of those premature babies is just spectacular these days. It's just amazing. And so triplets are doing well, but we don't like it. We're scared of triplets.
Okay, Dr. Silber, your last question for this evening is from Emily. She asks, what's the best course of action after a miscarriage that was the result of bad medical advice from a fertility doctor and caused me to be scarred to attempt anything but timed intercourse ever again?
Well, I'm sorry that you had that terrible experience, but what we can do to prevent miscarriage is to understand what causes it. It could be that you actually do have a scar in your uterus, and we have to fix that with hysteroscopy. It could be that you have blocked fallopian tubes causing fluid to leak backward into the uterus. It could be that you have endometritis, which we can figure out with a endometrial curettage, which sometimes is called a scratch, but where we actually look at the tissue to see if you have chronic inflammation. Uh, it can be caused by the shape of your uterus, perhaps being a septate uterus rather than a normal uterus. And we can fix that also. So we have to just find out what the cause of the miscarriage was. Now, if all those causes are taken care of, the most common cause of miscarriage is a blighted ovum or an embryo that was healthy enough to implant, but not healthy enough to really go on. And if that's the cause, it usually will occur sometime in the first 6 to 10 weeks. So I think the best way to deal with this, because if you need IVF, it's silly to just fool around with timed intercourse while your eggs are getting older. If you need IVF, best way is let's do a person-to-person consult and get all your data and decide what tests we need to do. Okay. So is that the last question for today? Because I think our time is up.
Yes, you do have a comment from Jimena again too. She says, "Great educational live. Thank you so much, Dr. Silber." So you answered her questions here.
Jimena, great. I'm glad to be of help. And we'll do this on a regular basis. If anybody wants to have direct person-to-person consultation, we do it at no cost. I'm in this because I believe that the first commandment is to be fruitful and multiply for everybody on the earth, from all people. And that's what's really going to make us happy in life. That's our chance for eternity, so to speak, is having that next generation. So I believe in what I'm doing, and I'm happy to talk to anybody with no charge at all. And I'm just reminding you that our website is infertile.com. Tons of material and information on that. In fact, all the Facebook Lives I've done are going to be on that website. And you can also call us. And it's really, we don't need business, but I'm really happy to make an appointment. And I work 80 hours a week because I love it, and it keeps me young. I do manage to swim a mile every day so I can stay young, despite the years. But just call us and make an appointment. We're glad to talk to you on Zoom. It's really easy. We don't have to schlep together to the office and waste a day. It can just be a simple Zoom talk. All right. Well, that's great. I'm Dr. Silber, and I really enjoyed this session, as I do all of them. And I guess I'm signing out now, and I'll see you again the next time. Bye-bye.